Hi there, guys. It's Dr. Erica Wood, and we're going to learn about something really cool. We're going to learn about digestion. And the reason why I love digestion topic so much is because it's interlinked with so many of our other processes of our body. So, digestion is not just about eating and making it feel good and having it go out the pooper. Digestion and the whole mechanism is about nourishing your body and making sure the body has the tools that it needs to rebuild and restore the body to how it should be. There's a huge link between gut and nervous system, and some may notice, some may not, but sometimes before a big test, sometimes someone gets really nervous and they feel like they have to throw up, or they feel like that they have to have a bout of diarrhea or can't poop. That just shows us how much our nervous system and our GI tracts are interlinked. We're going to start the lecture, and we have started the lecture, but we're going to start the lecture, and I'm going to bring up our material here, and then we'll be right in. Okay. So let's see here, share our screen. Okay, so we're going to chat about digestion. This is chapter 23. Ignore the part A part because I just changed the slides. So what is our job of digestion? So yes, it's to nourish our bodies, but its main goals is to break down the foodstuffs that we're eating into nutrients that our body can use to get into our cells. And how do we do that? We break it down in the gut. The gut is lined by a bunch of lacteals, which are lymph vessels, and a bunch of really small capillaries, and that helps absorb those micromolecules into the bloodstream. And what do we do when we have too much or we don't need it all? We poop it on out. So we get rid of the indigestible remains, which is feces. So a fancy name for the digestive tract or gastrointestinal tract or GI tract or gut is called the alimentary canal. And this canal basically starts from the mouth and ends at the anus. It runs together in one smooth conglomerate. There are areas that it breaks up, and there are sphincters. We'll talk about in a few moments, but digestion is actually the breakdown of food into its smaller fragments. Absorption is how we absorb it into our body, and we'll get into this in the next part of the lecture, but its purpose is for to be an anabolic purpose. So digestion is catabolic, which means it breaks down things. When we're done with digestion, we need to use that stuff. So it's anabolic, means to build. And the major organs that we need to know about are the mouth, pharynx, esophagus, stomach, small intestine, large intestine, and anus. We have a couple of accessory digestive organs that are really important, and you guys will be all up in that very soon in the mouth. We have our teeth right here. Teeth are really important for grinding and tearing at food and make sure we can bite it down to smaller pieces. The tongue is really important because the tongue not only has our taste buds, so we realize if something is good to eat or not, but tongue also is a muscle and helps move the food around our mouth, and also helps bring it to the back of or down the hatch or back of the throat to bring it into the esophagus. We have our gallbladder. Gallbladder's job is to store something called bile, and we'll get into that in a little bit about what bile does. And then we have some glands that help us break down our food stuff. So it's not just about chewing it, sticking it down in the stomach and praying and hoping for the best for it to come out the other end. We have salivary glands, we have a liver, and we have pancreas that have a digestive aspect. So you are responsible for knowing how to find things on a model or on a diagram about parts of the digestive tract. So you should know the mouth and tongue pretty well. There are 3 salivary glands that we'll get into a little bit: the parotid gland, the sublingual gland, and the submandibular gland. We have the esophagus, which then runs directly into the stomach, which is in the left upper quadrant. We have the stomach that goes contiguous into the duodenum, the jejunum, and ileum. So the small intestine is broken up to 3 parts. The most proximal part is the duodenum. Most distal part is the ileum. Right here, right around here in the right lower quadrant, we have the changeover from the small intestine to large intestine. This thing called the ileocecal valve that lives there. You also have your appendix, and that changes into the large intestine. So the first part of the large intestine is known as the cecum. Cecum then comes around to become the ascending colon, which is on your right quadrant or right side, your right flank. We have the transverse colon right here, descending colon coming down. We have the sigmoid colon. Part of the sigmoid colon is actually behind something called the peritoneum, and then becomes the rectum and the anus. And that is your digestive tract in a nutshell. So there are a couple of terms that we have to understand about what's used in digestion. We have ingestion, which is the actual process of eating. So we ingest food. We have propulsion, which is the movement of food down the tract, down the hatch. So that includes swallowing and also includes something called peristalsis. Peristalsis is a cyclical pattern of alternating waves, a contraction of smooth muscle and relaxation of it to kind of go like this, like shoo, boom, shoo, boom, and it moves the food down the track to your pooper. We have the mechanical breakdown of food, as I mentioned, with our mouth, and we are chewing the food. Chewing the food helps mix the food with saliva. Saliva has, we'll talk about in a little bit, some enzymes that help start the first part of digestion. In the stomach, our stomach is literally churning. How it works is that it squeezes and then it kind of rings itself around to move food in and around so we can get the most digestion that we can out of that. And then we have something called segmentation. Segmentation is the area and local areas of the intestine that constrict, so it hasn't a chance to mix the food with our digestive juices. Digestive juices, I know you're going to hear me say that a lot, are our digestive enzymes, things that break down our foodstuffs into smaller aspects. So we already talked about what digestion is. Digestion is catabolic. So it's the breakdown. Absorption is bringing it back into our body, whether it be by blood vessels or lymphatics. And then we have defecation. Defecation is a very fancy way of saying pooping. Okay, this helps eliminate our indigestible substances via the anus in the form of feces. So this is taking a look where things are occurring. Majority of our digestion, as you can see here, is actually occurring in the small intestine. That is where the majority of our digestion occurs. We have a lot of the breakdown here, a little bit of breakdown, but the digestion and the absorption aspect, most of our enzymes come to play right here in the duodenum. So we'll learn more about that in a moment. So the digestive organs are in our gut, and just like any cavity, the cavity has a name. So in the for the heart, it was the pericardial cavity. In the lungs, it was the pleural cavity, and in the gut, it's the peritoneum. The peritoneum, just like all the other cavities, are lined by a very thin serous membrane, and it's double lined. We have the visceral peritoneum, which is on the external surfaces of most of the digestive organs. And then we have the parietal peritoneum, which lines the body wall. And just like with all of our cavities and all our serous membranes, it makes a fluid so we can have fluid between the two peritoneums, and it allows the organs to have some mobility and lubrication. So if we're moving left and right, up and down, our gut organs are going to move with that. If there was nothing to lubricate the system, they would constantly have friction against each other, and that wouldn't be good. It would be painful. It would be causing areas to erode, eruptions of your stomach. Not fun times to have there. And then we have an area of, and it's actually now classified as a new organ of the body. It's called the mesentery. So if we come back up here, sorry to go back. So imagine if we took this area away, and you can look at it in your textbooks. If we took away the small intestines, you would see a fan of fat that's attached by a stalk to the back wall of the abdominal cavity, and it's called the mesentery. And what the mesentery does is it gives a place for all the digestive organs to kind of, or at least all the small intestines to have a place to anchor to. It also provides a route for blood vessels, lymphatics, and nerves to get to the GI system. And it holds our organs in place and also stores fat. We have a couple, so you'll hear a little bit about something called being intraperitoneal and retroperitoneal. So when we go behind this mesentery, we're actually going behind the peritoneum. So that is a cutoff of where in planes of where in our body. So when we are intraperitoneal, or the peritoneal organs, they're organs that are located within that peritoneum. We have some retroperitoneal organs, which means that covering does not cover them anymore. They're outside, they're posterior, they're in our left and right flanks. And this includes most of the pancreas, parts of the duodenum, and parts of the large intestine, mainly the sigmoid. And then when we get to kidneys, you'll learn that kidneys are retroperitoneal too. So just like with any other cavity, we can have itis, which is inflammation. So peritonitis is the inflammation of the peritoneum. You can get it by someone stabbing you in the stomach, a perforation of an ulcer, a ruptured appendix. So when people have an appendicitis, it's a medical emergency, because if that appendix ruptures, and all that yucky infected debris goes all around, guess what? That's swimming in all that peritoneal fluid and can cause sepsis, which is really bad. Sepsis is poisoning of your blood. How do we treat peritonitis? We normally remove the debris with surgery, and then you get a large amount of IV antibiotics. So as far as the histology of the gut, we've taken quite a few views of what the gut looks like under the microscope throughout the quarter, so I really don't want to go in too much depth here. We'll do that in lab. But there are four basic layers, or called tunics, of the gut. We have the mucosa, which is the epithelium. Depending on where you are in the GI tract, it has a different epithelium. So in the esophagus, it starts out as simple as a stratified squamous epithelium and becomes more columnar epithelium as you make your way down. In the stomach, we have simple columnar epithelium along with the rest of the GI tract. Okay. As the mucosa, we know it secretes mucus. It has some digestive enzymes that are housed in there and hormones. It helps protect against the infectious diseases of the gut, and it can also absorb the end products of digestion. We also have a submucosa, which is where all the blood and lymphatics vessels occur. So remember when we were talking about lymphatics, there was this mucosal associated lymphoid tissue. We see that in the form of Peyer's patches in the duodenum. We also have a lot of our nerve plexuses in there. Remember, gut nervous system links. So there's a ton of nervous tissue innervating this gut. And just like with anything, if we need stuff to be able to go into a tube, we need that tube to be able to be elastic and expand and come back to its shape after we're done. So the submucosa has a ton of elastic tissues to help that happen. We have our third layer going from superficial to, inside the lumen, we're going to consider it superficial. So we're going superficial to deep. Muscularis externa, which normally contains an inner circular muscle layer and outer longitudinal layer. And what these do is that when they contract and relax, they cause that peristalsis to happen. And then in certain areas of the body, these circularies become really thick sphincters, and sphincters are, the mouth technically is kind of a sphincter. Not truly, but if we want to think about puckering your lips like this, puckering your lips is causing something to close. And that is what these do. Sphincters allow ability to close so we don't have mixing of contents where we don't want it to mix. The most common sphincters are in the upper esophagus, lower esophagus. From the stomach to a duodenum, the ileocecal valve is technically a sphincter. And then we have the anus, which has an internal and external sphincter. So for blood supply of the gut, we call it the splanchnic circulation, and we'll learn when we get into embryology that splanchnic is an embryological term. All the branches of the gut arteries come off the aorta for the most part. The major branches that you're responsible for knowing about what gives the gut some blood supply is the hepatic, splenic, and left gastric arteries. It's a good thing they're named about where they're supposed to go. So hepatic, liver; splenic, spleen; gastric, stomach. And then we have the inferior and superior mesenteric arteries, and they give supplies to different parts of either the small intestine or large intestine. And then we have a new type of circulation that we haven't really discussed too much in the past yet. It's called the hepatic portal circulation, or enterohepatic circulation. And what this does is that when we get foodstuffs into our gut, and we absorb it absorb what we need into the bloodstream, we need to normally process those things and have a little extra added so we can use it a little bit more. So what the hepatic portal system does, it drains the nutrient-rich blood from the digestive organs and delivers the blood to the liver to process it. So there's a lot of things that control digestion. So fun fact, digestion starts before your mouth even gets the food. So probably have heard about Pavlov's dog in psychology. And Pavlov's dog is that every time they ring a bell, they condition the dog to salivate. When we see food, we smell food, we think about food. So I want you all to think about the most yummiest dish you ever had. Okay, I'm thinking about a magical moment on the top of the Hollywood Hills for the best sushi I ever had. My mouth is starting to water thinking about that, because what happens is that your brain gets senses that you are thinking about reminiscing of food. Your saliva is starting to build up, so it's getting ready to help you digest. And doing so, it's also telling your stomach, hey, we're maybe about to get some food. Let's get some of those digestive juices going as well. As far as the nervous system has a special name when it comes to the gut. It's called the enteric nervous system, and it's known as the gut brain and has more neurons than the spinal cord. So that's how you know 70% of our nervous system is in our gut. That's why there's such a great connection there. We have different parts of the enteric nervous system we want to concentrate on, but the most important thing is that the enteric neurons, they communicate extensively with each other. So they're constantly going, hey, I got food down here. Hey, I got food down here. Oh, I don't have food down here. And they're telling the body what to do, okay? As far as short reflexes, this is basically going from the gut brain, also the nerve plexuses that are inside the gut, and there's something locally that happens in the GI tract and the gut responds. And then we have long reflexes, which is more that rest and digest and parasympathetic system. So something in the outside world. Example, like I said in the beginning, we're getting really nervous for a test. Perhaps our sympathetic decides to turn on a little too much. When we rest and digest, we normally, it's having a proper bowel movement, but when our sympathetic is overfired, sometimes we get diarrhea or constipation. So that is an example of a long reflex. And as a naturopathic doctor, I like to always add, this is the bread to my butter, the PB to my J, the P to my pod, the gut brain, and how it's linked to our health. And it's not just nervous system. So there's some basic concepts that we need to know about to regulate digestive activity. So there's three key concepts. The first part is that the activity of our digestive system is provoked by mechanical and chemical stimuli. So inside the wall of the GI tract, there's receptors, and they respond to stretch, changes in osmolarity and pH, or if there's substrate that like starch, if there's a starch in there, then guess what? Our body knows that there's a starch, and there's a specific enzyme called amylase that comes down and breaks it down. And then it also responds to the end products of digestion, when to stop, when to start. We have the effectors of the digestive system, and those are our smooth muscles and glands. So when stimulated, we have those reflexes that occur that cause the stimulation of smooth muscle to contract and relax, to mix and move the contents around. And then these short reflexes can help activate or inhibit digestive glands if we need to. So moving right along, I think the rest of the slide is self-explanatory. So we have some functional anatomy of the digestive system that we need to review as well. So that was the basics of what our gut brain looks like. We have some associated organs: the mouth, the tongue, the salivary glands, and the teeth. And the mouth is where, remember, so before we even get the food in our mouth, we're already starting to digest. We're already getting our saliva going and some of those digestion processes going. You're going to be up in the mouth a lot. So I'm not going to go into super detail here about what you need to know, because you're going to get that in dental anatomy. But for purposes of my class, we need to know that there's lips, and they're called labia, and they're mainly the fleshy components of the auricularis oris muscle. We got our cheeks, which is the parts of the buccinator muscles. We have the oral vestibule, which is inside to the lips and the cheeks, and external to the teeth and the gums. With the oral cavity proper, which is within the teeth and the gums. So out here is the oral vestibule. Yes, I'm being a goof. The area where I, almost like a squirrel, where I can pack things in there, pack a nut in there, and keep it until I'm ready to chew it. I don't know if you really want to think about that, but when people do chewing tobacco, that's where it goes, in the oral vestibule. And then we have the oral cavity proper, which is within the teeth and gums, so inside here. And then we have something called the labial frenulum, right in here. I know that's really weird and freaky. It kind of looks like Terminator. But if you flip over your own lip, you will probably, unless you've had it cut, you will see a tiny little piece of tissue that hangs out just median to the lip of each gum line, and that's called your labial frenulum. I should probably use some hand sanitizer after doing that. In parts of the mouth, we know that's a hard palate, and that's made by the palatine bowls and the palatine processes, the maxilla. The mucosa on the top is slightly, has a little bit of ridging, and that's actually there for a purpose. It helps create friction against tongue, so our tongue is just not sloshing and actually has something to move against. And then we have our soft palate. So soft palate is closed off. The nasopharynx aspect is closed off when we swallow, because that would be important. We don't want to inhale food or choke on food. On the lateral aspects, the soft tissue is anchored by the tongue by what's called the palatoglossal arches. Excuse me. And then we also have the palatopharyngeal arches, and then we have areas called the fauces. I am not going to go into more depth on this because you're going to learn all about it. You probably already have in dental anatomy. So let's chat about the tongue. So the tongue, its functions is to grip, it's to mix, it's to help with the formation of something called a bolus. And what a bolus is in this aspect, is a mixture of food and saliva together. When we mix those two together, it's a bolus. Tongue helps with speech, which sometimes I get myself tongue twisted. Taste, as we learned in many other classes so far, and swallowing. The internal muscles, the intrinsic muscles, can help change the shape of the tongue. So I'm like this. That's helping change the shape of the tongue while I talk. And extrinsic muscles is how altering my tongue's position. So I don't know if you guys can see me in that aspect, but hopefully you are seeing what I am trying to show you. As far as, sorry, I just had to make sure I'm still recording. As far as the taste buds, we already went into that. I'm not going to go anymore. But there are some conditions that you might run into as dental hygienist called ankyloglossia. And that means that they're tongue-tied. So that frenulum is either really short or really thick, and it restricts how much the tongue can move. It's something I actually do in my practice, and well, I used to do in my practice, I might restart again, is that you take a pair of sterile scissors and you just clip. You clip the tongue tie, and you do exercises to make sure it doesn't form back. There's also now a cold laser that a lot of people like to use, and that laser helps just make it real quick and simple. As far as salivary glands go, the saliva, we know about it, we drool, yep. It helps clean the mouth, it helps dissolve the food chemicals for taste, it helps moisten our food to make it so we can make it more into a more compact bolus. So imagine getting anything dry down the hatch, that would stink. And then this is where our first enzyme comes in place. So we have something called salivary amylase. And what salivary amylase does, it starts breaking down some of the starches. So if you ever left a saltine in your mouth, so if you left a saltine in your mouth, it's got a lot of salt. But what ends up happening is that the amylase in your saliva starts breaking down, and it starts tasting sweet if you start leaving in your mouth. Most saliva is made by our major salivary glands, which we'll chat about. And then there's a bunch of minor salivary glands that help, but I'm not going to get into those in depth. The three glands that you need to know about are the parotid, the submandibular, and the sublingual gland. So right here is that parotid gland. It sits right here just along the cheekbone, just above the masseter. Cranial nerve 7 actually runs through this, but it does not innervate it. So it runs through it, but does not innervate it. It has a duct that opens up to the back just above the second molar on your upper jaw. And you can actually, if you took a finger, I don't recommend doing this because you might gag yourself, but we can actually take a pinky or a finger and feel that duct opening. Sometimes we get something called salivary stones or sialolus, and those are little rocks, almost like a kidney stone or a gallstone that can get stuck in that duct and cause lots of pain and inflammation. We also have our sublingual gland, which is located right below the tongue right here. And we have our submandibular gland. And each of these glands actually have different compositions of what's inside of them. So there's two different types of cells that are in a salivary gland. We have serous cells that produce the watery secretion and a lot of the enzymes that we see, like the salivary amylase. And then we have mucus-producing cells, the mucus cells. The parotid and submandibular have mostly serous cells, so they make mainly the saliva and the enzymes, and the sublingual gland is mainly mucus. And some things that are really important to know about the saliva, what's inside of it. It's mostly water, so it's hypoosmotic. It's got a slightly acidic pH, which would make sense because a lot of times we need that slightly acidic pH for our enzymes to work better. We have a couple electrolytes in there. As I said, there's salivary amylase, and there's a little bit of lingual lipase, but not really much to really do anything major. We have lysozymes and IgA, which we know are our immune system components. We do have some waste in there, so there might be a little urea and uric acid, and when we go over kidney next week, you'll be like, ew, gross. And there is a condition that you'll run into very frequently called xerostomia, and that's a fancy term for dry mouth. It means that's too little salivary gland action going on. It can cause difficulty chewing and swallowing and cause lots of infections. Chemo medications can do this. Diabetes can do this. There is an autoimmune condition of Sjogren's syndrome, which is where the body attacks its own glands so it can't make saliva. So you have dry eyes and dry mouth. When it comes to what's the next down the hatch, so we made it into our mouth, we made a bolus of food, and then we get it into our pharynx. So we have the food that goes into the oropharynx, that's a laryngopharynx. We have a whole, so remember that the inside of the mouth, once we get past the skin, is stratified squamous epithelium with some mucus producing glands. The skin is stratified squamous epithelium that is keratinized. Pharynx is non-keratinized. Then we also have the esophagus. So next step from the pharynx is to esophagus. So it's a tube, and it has a peristaltic wave, which means it contracts and relaxes to get food to move down into your stomach. It does connect to the stomach by piercing through the diaphragm. So at the level of the diaphragm is called esophageal hiatus, and it joins the stomach at what's called the cardiac orifice. And the first sphincter is not as important. So the upper esophageal sphincter, it's not really the one that loses its tone or really causes the most difficulties. It's our lower esophageal sphincter, also known as the cardiac sphincter, also known as the gastroesophageal sphincter. Those are all interchangeable terms. So what does the sphincters do is that when food is not being swallowed, it keeps the area closed. So stomach acid can't creep up and cause some really nasty side effects. And mucus cells on both sides of the sphincter. So there's some, remember that the lower half of the esophagus has more of that columnar epithelium, and so does the stomach. And what we're looking at there is we're seeing what the reason for that mucus to be producing is to help protect the esophagus from acid reflux. And what is acid reflux? It is painful. It is called heartburn. You feel it right behind your sternum, and sometimes can feel it when you're lying down worse, can cause chronic cough. It's normally happens when there's regurgitation of stomach acid into the esophagus. Now, not on the slide, but fun fact, many times we hear about using like Prevacid or PPI, which is an acid, stops your stomach acid from being produced as much. So it's actually more often than not that it's not that we have too much stomach acid being produced, it's that this lower esophageal sphincter is getting weakened, and that therefore it can't close properly, so we got regurgitation happening. So yes, when we put someone on a PPI, initially they feel better because there's lower stomach acid, but if we keep someone on that long term, it actually affects lots of other things down the road. So as a naturopathic doctor, I like to work on the tone of lower esophageal sphincter with certain herbs, and then we try to work the other way around. But once again, speak to your doctor if you have any questions about that. Things that can cause heartburn are certain types of foods, whether you drink too much or eat too much. Sometimes extreme boosty, pregnancy, and running can cause it. We can also have a condition where parts of the stomach protrudes up into above the diaphragm and gets stuck at the level of the esophagus. That's called a hiatal hernia. So fancy term, medical term for swallowing is glutition. And we have a couple of phases that I want you to know about. So we have the buccal phase, which its job is that the upper esophageal sphincter contracts and closes up here. And the tongue presses against the hard palate up here, and it's moving food back into the oropharynx. Then we have what's called the pharyngeal esophageal phase. And what's happening is that the tongue blocks the mouth, so nothing else is really coming in. The soft palate and the uvular rise, which closes off the nose, the nasopharynx, so nothing's going to go upwards. And then the larynx itself starts to rise so that the epiglottis, remember that little flap that protects our trachea, that will close so we don't choke on our food. And then the upper esophageal sphincter relaxes, and this allows food to enter our esophagus. Then we have the pharyngoesophageal phase that continues, and it's just doing some of the constrictor muscles of the pharynx that are contracting, forcing food into the esophagus downward. And then it's the same thing is happening as we're still moving down. Then we have a peristaltic wave that's moving the food from the esophagus to the stomach. So remember, it contracts, relax in a rhythmic motion that helps get food down the hatch. And then when there's enough pressure or enough volume or enough signaling from the nervous system, what ends up happening is that the lower esophageal sphincter, the gastroesophageal sphincter opens, allowing the contents to go into the stomach. And then as soon as the contents are lowered, it closes again to prevent any regurgitation from happening. So that brings us down to the stomach, the tummy, whatever you want to call it. So there's certain areas of the stomach that we need to know about. So the cardia is where the esophagus meets the stomach. So that's the first most proximal aspect. Then we come to the fundus, which is the most superior aspect, but more distal to the cardia. We then come into what's called the greater curvature, which is the most outer part of the stomach, which is longer, the lesser curvature right here. We get into the pylorem right here. And so then we also have the body. The body is the majority of the stomach right here. We have the pyloric antrum right here. And then we get into the pyloric sphincter, which the pyloric sphincter is a fancy term for a valve that basically opens and closes to get food out of the stomach into the duodenum, okay? The most fascinating part here is that a lot of times, we'll go into this, but sometimes when people have gastric bypasses, they'll remove part of this, either part of the fundus or part of the body to shrink up the stomach. What ends up happening is that you are losing some of your ability to digest food as well. Hanging off the stomach here, we have something called the greater omentum, and that goes over the intestine, the spleens, and transverse colon. It contains fat and lymph nodes, and it is considered a protection mechanism. So it's one more step to protect from things from the outside world. Blood supply, nerves of the stomach. So the celiac trunk, which is a branch off the aorta here, goes in gastric and splenic branches. And then veins of the hepatic portal system supply the stomach. Our autonomic, remember, we don't have any control of anything besides our mouth, of how much we move it, and how much we chew, and where we put our tongue. After that, it's all up into the autonomic nervous system's phase. So sympathetic nervous system does have certain branches that can come through and play along, but it's really that parasympathetic, that rest and digest, that we're concentrating on. As far as the stomach, we have different types of cells, and they're in different types of areas. We have secretories. Most of these glandular cells are in the fundus and the body, and they produce more of the gastric juices. And then we also have glands that are making secretory cells. So we have mucous neck cells, which make a little bit of acidic mucus. We don't really know what they do. They're there. The key ones that I want you to know about are the parietal cells. Parietal cells are super important. They're actually what's responsible for making that hydrochloric acid, the stomach acid, helps break down and denature some of the proteins, break down some of the plant cell walls so we can actually digest our food. It also makes intrinsic factors. So intrinsic factor, what it does, it helps shuttle B12 into the small intestine. And then we also have chief cells, and what chief cells make, and this is really important too, they make an inactive enzyme called pepsinogen. And then when the pepsinogen hits the hydrochloric acid, it becomes pepsin, and this is a positive feedback, and that helps digest proteins. Has a little bit of lipases in there as well. And then we, so remember, gut health, gut brain, gut nervous system, gut all linked together. So we have something called the enteroendocrine system, and what that's doing, it's making hormones. So we have paracrine hormones, which means they react locally, and serotonin and histamine are really important here. So a lot of times when someone's on a serotonin reuptake inhibitor, they might notice some GI issues that come along with it. And then we have a hormone called somatostatin, which helps stop. So statins stop. So statins can help stop some of the digestive process and gastrin. And so as far as, I'm sure everyone's heard about getting ulcers in your stomach from lots of stress or whatever's going on, the main protection against ulcers is our mucosa. And our mucosa has a ton of bicarbonate-rich mucus that helps keep the bad for us bacteria at bay. So H. pylori is a common thing that causes duodenal or peptic ulcer disease. There's tight junctions between the cells, and that prevents the juice or the digestive, the stomach acid from getting into this tissue itself. And then we have lots of replication here. So surface cells are replaced every 3 to 6 days. So there's always a fresh brand new mucosa for you guys to have. We have a couple of conditions here that you'll run into as clinical dental hygienists. We have gastritis. Remember, itis means inflammation. So anything that's breached that stomach's mucosal barrier can cause gastritis. And they have peptic or gastric ulcers. They cause erosions in the stomach wall. And if these erosions become too much, they can perforate and lead to that peritonitis and hemorrhage. We talked a little bit about H. pylori. Most stomach ulcers are caused by H. pylori, but also high doses of aspirin and NSAIDs like Tylenol and ibuprofen can really do a number on stomach linings. So this is an example of a gastric ulcer. So you see right here, some of the wall has been eroded, and it's kind of looks scary. If you do not ask me questions about how to treat that, you have to ask your doctor about that. Okay. Digestive processes in the stomach. So stomach has a couple of goals. It's not just to, make you feel hungry. It helps further break down food. It helps hold on to the food until the rest of your digestive tract is ready for it. We have something that's called chyme, and chyme is after the stomach acid and the food has mixed together and broken down. It's formed something called chyme, and that delivers it to the small intestine. And then the HCl, the hydrochloric acid in the stomach, helps denature some of the proteins so our enzymes can work a little bit better. Pepsin, remember, carries out some of the enzymatic digestion proteins. So casein is a milk protein. And it's so example for breastfed kids or formula-fed kids somewhat, milk protein casein is broken down to renin. And that renin is sometimes when we see kids with a little bit of upchuck after they've been feeding, that's actually that curdy substance that you see come out. But it's there for a reason, because babies drink milk and our bodies don't fully able to digest it properly, so that pepsin helps carry it out. Also, some lipid-soluble alcohol and aspirin are absorbed into the bloodstream here, so that's why aspirin plays such a big role on pain, also on ulcers. And then the stomach's function is essential to life, so we need that intrinsic factor of B12. If we don't have intrinsic factor, it's called pernicious anemia, and we can't absorb our B12. Remember, we need B12 to replicate our red blood cells, and we need it to be mature. How do we treat this? Old school is to do B12 injections. Depends on how your digestion is doing. Okay, so how do we regulate our gastric secretion? So approximately 3 liters or more of gastric juices are made per day. We have neural mechanisms. So the vagus nerve stimulates the digestive juice secretion. So remember, vagus nerve, cranial nerve 10. And then we have the sympathetic stimulation, which decreases the secretion. So remember, rest and digest. So vagus nerve here is probably going to be parasympathetic if you thought about that. And sympathetic is that we decrease the secretion. We stop the digestion. And then the hormonal mechanisms, the gastrin, that stimulates the hydrochloric acid. And then there's a gastrin antagonist that's made by the small intestine that helps regulate that HCl secretion. Our stomach has a couple of responses about as far as how we get stomach contents to move and empty. So they respond to stretch receptors, and those stretch receptors accommodate for the incoming of food. So bloop, we get our stomach to stretch up. We have a receptor for relaxation, and that causes, that's actually kind of in combination with the swallowing center of the brainstem. And then we have called gastric accommodation, which is the internal ability of the stomach's smooth muscle to have a stress relaxation response. And remember that peristalsis occurs in the stomach, but we also have what's called churning occurring. Okay. When it comes to, hold on, that's the old slide. That's the end of the slide set there. I'll be back in just a moment. Okay, so I had to make sure my screen share was correct. So let me get my screen share back up here. Okay, so we already talked about that. So peristaltic waves in the stomach, we have propulsion, which is the waves that move the food from the fundus to the pylorus. We have the grinding, which is peristalsis that helps mix everything, so that churning. And then we have retropulsion, which is actually a peristaltic wave that closes that pyloric valve, forcing the stomach contents to go back. So literally it's like vroom, 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 vroom. So if you think about trying to climb a rope when you're trying to go like this, but in backwards too. Okay, so these are just showing how our neural and hormonal factors inhibit gastric emptying. I'm gonna have you guys take a look at this but basically what inhibits gastric emptying is the presence of fatty acid or hypertonic or acidic chyme in the duodenum. So what's happening in the duodenum is going to signal back to the stomach. So a couple of things that you probably have lots of experience with or not is vomiting, which the medical term is emesis. It's caused by extreme stretching of the stomach, and it can be caused by intestinal irritants such as excessive alcohol, spicy foods, certain drugs. And how it occurs is that there's chemicals and sensory impulses that stimulate the area of medulla that's called the emetic center, and it is literally your brain telling you, this is not something we need in our body, get it on out. Hence, we don't want to binge drink. And then excessive vomiting can be a huge problem because we're losing all the electrolytes and all those, and a little bit, lots of water. So it can cause dehydration and can alter our acid-base imbalances, causing a metabolic alkalosis. We have some other key players here that we want to keep in mind. So we have the liver, gallbladder, and pancreas. So the liver, it's a digestive, its job is to make the bile. Gallbladder, store the bile. Pancreas, its job is to make, besides the insulin and glucagon that we learned about before, is to make most of the enzymes needed to digest the chyme, as well as secrete some bicarbonate to help neutralize the stomach acid once it hits from the stomach to the duodenum. And bile itself is like soap. Bile is meant to emulsify fats. So when we put soap onto soap into something, helps break down all those fatty layers and flush it away. That's what bile is doing. As far as the liver, the cells of the liver are called hepatocytes, and they produce about 900 milliliters of bile per day. They process bloodborne nutrients. So glucose, the liver is really big on making glucose stored as glycogen and plasma proteins. They store some of the fat-soluble vitamins. We'll go into that in a little bit. Very important for detoxification processes and what's called conjugation, or transforming some of the things in our body. Bile itself is this yellow-green, basic, slimy stuff. It has some salts in there that are made from cholesterol, and they help emulsify the fat and help it absorb. And then we have bilirubin, which is from the breakdown of heme. And this is what ends up happening is that the good for us bacteria in our gut actually digest the bilirubin, and it becomes a stercobilin, and that gives the poop the brown color that we see. When we have when the poop looks yellow, that means our fat's not being absorbed really well, or there's a bacterial infection. When there's too much green, sometimes that's mainly from vegetables or inappropriate breakdown of bilirubin. White means that we're not getting any of the bile in, and that's something to look at the gallbladder for. So we have this system called the enterohepatic circulation. So we're going to go into that. What does it look like? So we have the bile salts that are secreted into the duodenum. The bile salts then travel through the small intestine, and they allow the lipid digestion and absorption to occur. That's their big thing. And so enterohepatic circulation is all about reduce, reuse, recycle. So it's a recycling center. 95% of these bile salts are reabsorbed by the ileum, which is the most distal part of the small intestine. And those reabsorbed bile salts then travel back to the liver via the portal vein, and they're recycled. So only about 5% of bile salts that we have in our body at all times are new. So we do a lot of reduce, reuse, recycle. When the liver is out of balance, or some things that can occur, hepatitis, which remember, itis means inflammation. It's normally done by a viral infection such as Hep B or Hep C. Drug toxicities occur, such as overdose of ibuprofen. And then don't go eating any shrooms that you don't know what they are, because wild mushrooms can poison and cause hepatitis. Cirrhosis is when hepatitis has gone too far. So it can be done either through a high carbohydrate, not great optimal diet, or alcoholism. So first starts as liver gets fatty deposits called steatohepatitis. And then there's fibrous tissue that responds to that. It lays down scar tissue, and it causes something called portal hypertension, which is high blood pressure in the portal system, which is a danger. We could cure these normally with liver transplants if it gets the cirrhosis. And remember that we can survive with about 80% of our liver. Our liver regenerates really fast. So you can remove 80% of the liver, and in about a year or two, it could be back to its full size. The gallbladder is a sac that hangs off the liver, and its a main function is to store and concentrate the bile. And what it does is it absorbs water and ions. But for what I want you guys to remember is that it stores the bile. Okay, it has a little bit of these honeycomb folds that help expand and that allow it to expand, so it can fill up as much bile as it needed. And then when we need this bile, we'll get a hormone contact, and it'll cause the cystic duct to do little muscular contractions and allow this bile to go into the bile duct. And a fun thing that happens with gallbladders is that they can make gallstones. And this is typically what we call the 4 Fs. It's female, it's a fertile female who's 40. And I don't like using this term, but it's a way to remember it. It's FAT. I don't believe that should ever be used in describing something, but it is a precursor. And what happens, these gallstones normally can obstruct the cystic duct or even the bile duct, and can be very painful and can cause jaundice, which is when the bile salts build up and can't be recycled, you get yellowing of the skin. So typically this is done with surgery. I don't really know many people who do any other of the options there. And the pancreas. So we learned about the endocrine system of the pancreas. Now let's talk about the exocrine. So exocrine, so the pancreas is in the left upper quadrant. It is mostly retroperitoneal, and it's deep to the greater curvature of the stomach. It comes in with, so imagine this is the head of the pancreas. Here, this little C shape here is the duodenum. It fits just right in there because the pancreas will empty out its digestive enzymes directly into the duodenum through a hole called the ampulla of Vater. Okay, and we'll get into that in a little bit. The exocrine makes what's called pancreatic juices, which are digestive juices. They're done with acidae. Acidae are the ones who secrete it. Ducts are the ones that get it down to where it needs to go to. The main digestive enzymes here are proteases, which help digest proteins, amylases. So there's a salivary amylase and there's a pancreatic amylase, and those are for carbohydrates. Lipases break down lipids, and nucleases break down nucleic acids. And then we also have to remember that there's insulin and glucagon. So insulin is anabolic, so remember it builds. So after a high sugar meal, it's going to bring the blood glucose into the cells to use it to build. And then glucagon responds to low blood sugar and means that we need to bring it back up. So it helps break down some of the sugar storages of glycogen in our muscles and in our liver to help fuel us to go when we're in starvation mode. So here's that little ampulla of Vater that I was talking about. It's also known as the major duodenal papilla. So we have two ducts, major ducts that we need to know about the pancreas. We have the main pancreatic duct and the accessory pancreatic duct. Sometimes these open to the same place, sometimes they don't. But most of the time they open into the same aspect right here into the major ampulla. Some people do have a minor papilla. It's a variation amongst everyone. But the main important thing here to know is see how everything's in close conjunction with each other. We have the liver up here, the gallbladder hanging out here. See how we have all these connections of the ducts right here from the gallbladder. Cystic duct goes into the bile duct then gets secreted. So bile goes into the same spot as the digestive juices of the pancreas, into the ampulla of Vater, into the duodenum, okay? As far as the small intestine goes, so we already kind of reviewed a little bit of it. So there's three major divisions. The most proximal part is the duodenum, and that's mostly retroperitoneal. And remember that thing that I showed you, the pancreas here, the duodenum here, with the jejunum, which is the next aspect, and that's mostly attached by the mesentery. And then we have the ileum, which is part that's attached at joints to the large intestine at the cecum at what's called the ileocecal valve. So here's a picture representation of what everything looks like. So duodenum is the most smallest aspect. And microscopically, this small intestine is amazing because if you took all the little folds which are called villi, and we unfold it all, it would, I think, take up, if I believe, about the size of 1 or 2 football fields or the size of a tennis court. So what we have here is we have these circular folds that are permanent folds in the actual small intestine, and they help force the chyme to go through the lumen and allow for more time for nutrient absorption. We have villi, which are little finger-like projections of the mucosa, which you've seen under the scope that we've looked at already. And these have these capillary beds, lymphatic beds called lacteals, and what they do is they absorb things, especially the chyme, especially the fat as well. And then we have microvilli, and the microvilli are on top of the mucosal cells themselves because of that brush border. And this brush border actually contains things called brush border enzymes. And yes, we had a lot of amylases come through. We're still breaking down. Guess what? We're still not at the micro level of glucose that is easily taken up by the cells. So we have brush border enzymes that help that final process of carbohydrate and protein digestion to make them small enough amino acids and glucose to come into our cells. So this is just looking of what we were looked at before under the microscope. So this is a villi right here. It's lined by a bunch of these mucosal cells. Each mucosal cell has that brush border right here. We have other cells that we need to pay attention to in the small intestine. We have goblet cells, which make mucus, which is really important. We have enteroendocrine cells. So 2 of these are examples of called cholecystokinin and secretin, and they help with digestion. We have something called Paneth cells, And Paneth cells secrete antimicrobial products like lysozymes and defensins that help destroy bacteria. So yes, there is a ton of bacteria in our gut. There's good for us bacteria, but then there's also bad for us bacteria. We have stem cells because we need that gut to constantly restore itself. And gut cells love the amino acid glutamine and helps them rebuild. So enterocytes are the actual gut cells that line everything. So where's my immune system at? I feel like, where my girls at? You want to do that song. Sorry, I'm embarrassing myself again live. But so immune system, we have that MALT, the mucosal associated lymphoid tissue in the form of Peyer's patches. And we find that greatest number is found in the small intestine, and then we do have it in the duodenum as well. I might have said it opposite beforehand, and I apologize. And then digestive processes. So it takes about 3 to 6 hours in the small intestine to absorb all the nutrients and most water at this point. So chyme from the stomach is partially digested. And remember, those brush border enzymes and the enzymes for the pancreas are really what breaks it all down to funky town. Okay. So we need bile, we need bicarbonate, we need digestive enzymes, we need brush border enzymes. Everything is important. And that ileocecal valve stops the backflow from the large intestine to the small intestine. So it's a barrier. We don't want stuff to come from the large intestine, which we didn't want because it's waste, coming back up into our small intestine, because that's bringing crap, no pun intended, crap that we don't want in our system. And that brings us to the large intestine, which is where the crap goes. So large intestine has 3 unique features that are not seen anywhere else in the intestine area. We have these things called tenea coli, and there are 3 bands of longitudinal muscle, smooth muscle that's in the muscularis. We have hostra, which give those little pocket-like sacs that we see when we're looking at a diagram. And we have something called appendages, which are these little fat-filled pouches, sometimes house a little bit of the lymph nodes here. So here are those hostra right here. Here's that, here's some of the epiploica right here. And then I'm trying to see right here. So epiploica is right here, and then tenea hostra is running this way, that longitudinal band. So what holds it all in there? How does our gut not just go bleh and come out of our bellies? So the cecum, appendix, and rectum are all retroperitoneal, also part of the sigmoid colon as well. And then colon, the colon itself is also retroperitoneal, except for parts of the transverse and sigmoid. So let me reverse myself there. So there are parts of the sigmoid colon that are still retroperitoneal. Transverse colon is not retroperitoneal. The ascending, descending colon are not retroperitoneal. What is retroperitoneal is the rectum, cecum, appendix, and part of the sigmoid. And then intraperitoneal regions, they're all anchored by the mesentery, but it's also, there's still tiny little aspects called mesocolons that hold it together. So this is taking a look, if we lift it up, that mesentery, that fat apron that's hanging off our transverse colon, take a look on the inside here. This is all that mesentery. See right here where this is where the duodenum stopped, and this is where our jejunum started. Mesentery is holding everything together, and you can see right here that right here, part of this, as it turns into the rectum, that little part right there, the sigmoid is still retroperitoneal. The rectum is all retroperitoneal. And then part of the cecum is retroperitoneal also. We already talked about appendicitis, but I'm sure everyone's familiar with it, but it's always good for a review. Remember, itis means inflammation. So most likely cause is that where our poop gets stuck in there and the bacteria get a chance to fester. Typically, the person will start with what's known as pain in their belly button area, the umbilical region, that will move down to the right lower quadrant. We'll see loss of appetite, nausea, and vomiting. And sometimes that can rupture, and that's really dangerous. So we always want to get someone checked out. So this is the most awesome thing that I've learned as a naturopathic doctor in my life. It's flora. So flora is bacteria. Our skin has flora, our mouth has flora. You'll learn about dental films when you get into dental anatomy, and our gut has flora. This flora is there for a reason. Yes, we are mostly a bunch of bacteria, not a human. That's kind of scary, huh? They outnumber our own cells 10 to 1. And they come in from the small intestine or anus, and they colonize the colon. What their job is they're super important. When we have the good for us bacteria, known as the flora, then what they do is they help ferment things. So they help digest some of the carbohydrates that we can't digest, and they use those as their own fuel. And sometimes they can release, when we have fermentation, we have a little bit of irritating acid and gases, but that's part of the process. And bacterial flora also helps synthesize B complexes, so B vitamins and some vitamin K, which is needed by the liver to produce clotting factors. And also, there's been new links that if our good for us bacteria is outnumbered by bad for us bacteria, that affects our neurotransmitters. So that's serotonin, dopamine, those things that affect our mood. If we don't have the right bacterial balance, then we don't have the right serotonin. We don't have the right neurotransmitter balances. And remember, the gut makes a lot of serotonin too. It's not just the brain. So it also helps keep the pathogenic bacteria in check. So if there's a lot of good for you bacteria, guess what? The bad for you bacteria doesn't have a chance to build up and get bad. And then gut bacteria and health. So there's tons of evidence here that if you don't have a good flora mix, that it can lead to obesity. It can cause liver disease, fatty diseases. I already said about our mood. Autoimmune diseases are connected here. Diabetes. Basically, I can link, ask me how, and I can link just about everything to our gut health. That's how important it is, and having a good flora. And then when we manipulate our gut bacteria, it's a good thing because it helps keep our routine healthcare strategy in check. Okay. As far as digestive processes in the large intestine, so it doesn't really do any food breakdown. No food breakdown is occurring in the large intestine. So whatever's broken down in the small intestine, it remains in that large intestine for 12 to 24 hours. So the only thing that's really getting broken down is that good for you bacteria that's helping digest the parts that we weren't having the greatest ability to digest. What also is going on there is those vitamins that are made for the good for you, made by the good for you flora. Water and electrolytes are reclaimed here. So diarrhea and constipation are a huge play here because your large colon is what determines how much water goes into your poop, how much water comes back into the body, and electrolytes too. Remember, water follows sodium. And so its major job is to propel to make sure that the feces are staying there, propel it down to the anus and defecate. There is something called reverse peristalsis. It's very rare where people can belch or throw up vomit feces. Not very common. I don't think I've ever really heard much about it. I already talked about this irritable bowel syndrome. It's so common, very common. Basically what happens is you're getting these recurring abdominal pains, stool changes, whether diarrhea or constipation, bloating, farting, nausea, sometimes some depression. And after you poop, you feel better. That's the key here. If after you poop, you feel better, it's most likely irritable bowel syndrome. The big trigger for this is stress. And remember, gut brain, nervous system, stress, cortisol, boom, boom. Everything is linked together. And so stress management is something that is very important to keep a healthy bowel gut happy and avoid irritable bowel syndrome. Good gut health comes with good stress management. Okay. And then pooping, cha-cha-cha. Defecation, cha-cha-cha. So pooping is basically defecation. It's just moving the mass movement of feces towards the rectum. This is a reflex, actually. So distension in the large colon causes a spinal reflex called the defecation reflex. Parasympathetic signals. So when they realize that it's time to poop, it stimulates contraction of the sigmoid colon in the rectum and relaxes the internal and anal sphincter. So internal anal sphincter, we have no control over. That is autonomic nervous system. What we do, we do know that we can hold our own poop and decide when we poop for the most part, unless we get too full of poop. So the internal sphincter, we have no control of. Parasympathetic control. How we relax that, when we relax our external anal sphincter, that is skeletal muscle. We have control over that. So we can actually control when we poop and how. Okay, so other things that help out with defecation is that if you ever had to try to force poop out, you go, the Valsalva maneuver helps bring that pressure into the abdominal wall, helps increase the intra-abdominal pressure so you can push things. We have muscles at the bottom of our pelvis that contract, when we do this, that helps the anal canal to be lifted, so that if we lift the anal canal up a little bit, the feces can go down easier. And then muscles of the rectum actually do contract to help expel the feces also. So everyone probably knows what diarrhea is, but just in case you don't, I'm going to go really old school diarrhea, cha-cha-cha, because yeah, I'm a kid of the 90s. So diarrhea is watery stools. It's not on here, but it's classified as having watery stool. I like to actually show, I'm in my office, so I might as well show this. I like to show patients what's called the Bristol stool chart. It is showing you the different classifications of stool. So type 5 through 7 are considered diarrhea because they're not well formed. If you have poops more than 3 times a day, that is considered diarrhea also. So what's it caused by? It can be caused by so many things. Bacteria that has decided to irritate the colon, certain foods that irritate the colon. Commonly, people who can't digest lactose, the milk sugar, will have diarrhea. And something called runner's trots has occurred. If anyone knows anything about marathon running, basically what ends up happening is that the digestive viscera are getting jostled up, and that causes the body to release poop a little bit more than we want. Constipation is the other end of the spectrum where we aren't able to poop. It is really normal to be able to poop every day. Not pooping every day is considered constipation. Still becomes really hard and difficult to pass. And we have what's called the 3 F's here that help us with what I call be a champion of pooping. So 3 F's are make sure there's enough fiber, make sure there's enough fluid in the form of water, and also make sure there's enough fitness or exercise. And sometimes when there's lack of fitness or abuse of laxatives and like a bulimic person, this can cause constipation as well. As far as digestion goes, remember this is catabolic. This is the breakdown of the macromolecules into the monomers. Monomers are small molecules that are able to be absorbed. All these are done by enzymes, and enzymes require water, which is hydrolysis. Hydrolysis is the ability to use water to break down a chemical bond. When it comes to absorption, so we have tight junctions in our gut that help us better absorb. We have lipid molecules that can easily pass through the membranes, and then other polar molecules are absorbed by active transport. And most nutrients are absorbed before chyme reaches the ileum. So most of the digestion is actually happening in the jejunum. Okay, so we have a look here again of what that, if the brush border right here in the small intestine. So this is that brush border. This is the villi. And how do we process all these nutrients? So we got this stuff absorbed. What do we do with it? So digestion of carbohydrates, remember in the beginning of probably week 1, we went over a little bit of the basics of monosaccharides, polysaccharides, etc. We're going to revisit that now. So only thing that our body can absorb are monosaccharides. So remember, digestion begins in the mouth with salivary amylase. And then that salivary amylase helps break down these starches and disaccharides into what's called oligosaccharides and more disaccharides, depending on how big it was. In the gut, we're further broken down into lactose, maltose, and sucrose. And then in the brush borders, we're breaking down to monosaccharides, which are glucose, fructose, and galactose. So here's a little picture representation of where everything's occurring. So big important thing is that pancreatic amylase. We're taking a look at that because it helps break down starch or glycogen that has escaped the salivary amylase. So it's our next step in case the salivary amylase hasn't worked. Our pancreatic amylase has gone to play. I don't want you guys memorizing every single brush border enzyme. Just know there's a bunch of enzymes to help break down these disaccharides into monosaccharides. Okay. So we talked a little bit about lactose intolerance. So basically, your body doesn't have the right amounts of lactase to consume the lactose. So therefore, some people want to choose to avoid dairy or consume lactose-free foods. Then we have the digestion of proteins. So protein is we get our protein from food, but we also get it from the breakdown of other things in our body. So proteins are broken into what's called polypeptides on a larger scale. Smaller polypeptides are small peptides. And then amino acids are the smallest part that we can bring into our body. Sometimes there's a couple dipeptides or tripeptides there, but the big thing here is that digestion for proteins always begins in the stomach with pepsinogen. Once it hits hydrochloric acid, it becomes pepsin, and you need a pH of 1.5 to 2.5 for that to happen. And then we want to stop this happening from the time. So once that the chyme hits the duodenum, the pH of the duodenum is much higher and it inactivates pepsin. So here's another picture representation of where everything's getting digested for proteins. Lipids, also known as fats. So remember, we have the bile that helps emulsify and break down. So fats are made of a triglyceride and a phospholipid fat triglycerides are made of a fatty acid. Oh my gosh, I'm getting tired. Triglycerides are made of a fatty acid and a phosphate backbone. There we go. So we need in digestion, the pancreas is really the main area here that really does, it makes lipases, and that helps break our different types of fats into into a monoglyceride plus 2 free fatty acids. And then when it gets broken down even more, we have what's called a micelle formation. And this micelle formation is from digestion. It coats, it's basically the bile salts and something called lecithin has coated the area, which makes it easier to diffuse across the membrane. So here's taking a look there. Sorry if I'm getting tongue-tied. Maybe I need my tongue-tie clipped. I don't know. And I'm not going into too much details here, but pancreas has some nucleases, so does the brush border to break it down. Vitamins, electrolytes, and water. How do we get those suckers in, right? So there's certain things that we need water to bring those in, certain vitamins in, and we have things that are fat soluble. So in the small intestine, most of our vitamins are absorbed, or actually almost all of our vitamins are absorbed. Fat soluble vitamins are vitamin A, which is known for eye health, vitamin D, which we all know about. We use the sun to convert it. It's really important for immune system and calcium regulation. We have vitamin E and vitamin K. And remember, these are carried by those micelles. The micelles coat with the bile salts and allow it to be diffused into the absorptive cells. We have water-soluble vitamins, vitamin C and vitamin B. So these are either absorbed by diffusion or by passive or active transport. So vitamin C and vitamin B, if you ever notice, if you take your vitamin B on an empty stomach, you get diarrhea. You take too much vitamin C, you get diarrhea. It's because they're water soluble. And then we have vitamin B12. Remember, we need that intrinsic factor that is made by the stomach to be able to absorb it into the small intestine. And then in the large intestine, we have some of the B vitamins and vitamin K that's made from that good for you bacteria breaking down, and so we can use it. So as far as the electrolytes, most ions are transported actively along the length of the small intestine. Iron and calcium absorb in the duodenum. Sodium absorption is often coupled with active absorption of glucose and amino acids. And that's really all I want you to know about that. There is an issue that's called malabsorption, where something is interfering with our body to absorb things. So whether it's from bacterial infection, antibiotics, celiac disease, gut sensitivities. We hear a lot about people being sensitive to gluten, then we hear people actually having celiac disease. Celiac disease is an immune reaction to gluten. The gluten is a protein that causes immune cell damage in the intestinal villi and brush border of the duodenum. And what do? We just eliminate gluten from the diet. There are people who are gluten sensitive that don't have celiac that respond in the same manner. Okay. So then we're going to come up to our lecture here. I'm going to stop my screen share for a moment. We're going to come up to our lecture here on nutrition. Okay. So keep in mind, this is not medical advice. You're going to take a whole nutrition course, I believe, for dental nutrition in your course at PIMA. But this is some basic knowledge here. Once again, I am not your doctor. Do not listen to what I'm saying for you to do individually. This is just stuff to know for reports. Okay, I'm going to share my screen again. So when it comes to nutrients, we have macronutrients, which are carbs, lipids, and proteins, and we have micronutrients, which are vitamins and minerals. Water is a definite requirement of life, so I consider that a nutrient. We have essential nutrients that must be eaten because our body can't make it. We have non-essential nutrients that are also essential to life, but we have to bring that in through diet. And then energy itself of food, or how much we burn, is called a kilocalorie, also known as a calorie. And the calorie, exactly what it means, is the amount of heat needed to raise the temperature of 1 kilogram of water by 1 degree Celsius. So 1 dietary calorie equals 1 kilocalorie. So USDA has something called the My Plate that you can check out that gives guidelines that represent portions on a dinner plate. And the food groups that are represented here are fruits, which are the recommendations are only 1 to 2 servings a day. Vegetables, in my world, is ideally half your plate in some kind of leafy green or low glycemic vegetables. We have grains, which should be about 1/4 of the plate. Protein should be at 1/4 of plate, and dairy. You can survive without this, but according to the USDA plate, it's part of the plate and it helps you get some calcium in. And then there's some basic dietary principles like eat only what you need, so don't overeat. Eat plenty of fruits, vegetables, whole grains, avoid the junk, those type of things that you'll hear possibly your dentist talk about. So this is a picture of what choosemyplate.gov is looking like. And as I said, I like to have half of my plate vegetables and fruit as sometimes because too much sugar is not good for your immune system. Okay. Once again, not medical advice, just my personal opinion. So we talked a lot about carbohydrates already, and we have a good idea of what it is. Carbohydrates mainly come from plants and grains, and so that's grains and vegetables and fruit. Sugars come in the form of mono and disaccharides in fruits. There's sugar cane, sugar beets, honey, and milk. We have two different types of fiber, which are considered a carbohydrate. We have something called cellulose, which is insoluble, which is found in vegetables. It provides roughage, so our stuff can move through and bulk up. We have soluble fiber as well, which is pectin in apples and citrus fruits. It's been shown to reduce blood cholesterol levels, but it also helps provide a little bit more of gelin in there. And then a small amount of milk sugar. You see some glycogen in meats as well. So what do we use carbohydrates for? So glucose is the preferred fuel by most of our body to make ATP. ATP is energy that our cells use to get things done. So neurons and red blood cells, they rely completely on glucose. Without glucose, neurons die pretty darn quickly, okay? Excess glucose, guess what? Anything we do in excess can get converted into fat. So excess glucose is converted to glycogen or fat and then stored. Fructose and galactose are converted to glucose by the liver. So remember, liver does a lot of changing up of things before entering circulation. So we have things that are complex carbs and things that are simple carbs. Complex carbs have a lot of fiber and take your body more time to digest. Those are whole grains, quinoa, fiber-filled veggies like sweet potatoes and greens. And then we have simple carbs, which are fruit with little fiber, sugars, white breads, easy to digest but don't keep us full. And in the real world setting, a serving for a complex carb is about 1 cupped hand, and everyone has a different size cupped hand, so that is your personal cup. And eat low carb veggies often. So remember, half that plate of veggies is what the current recommendations are. Well, I think, are recommendations. And then, much to contrary belief, we need fat to survive. Fat is actually good for you in the right amounts and the right types. So triglycerides are neutral fats, and that's when we do a cholesterol test, we normally look at our triglycerides. We're found in meat, dairy, some certain oils, and hydrogenated oils. Do not eat hydrogenated oils, trans fats. They are not good for you. And then we have unsaturated fats, which are found in our plant-based items such as seeds, nuts, olive oil, and vegetable oils. We also have cholesterol, which is found in egg yolks, meats, organ meats, shellfish, and milk products. But remember, liver makes about 85% of your cholesterol. So that's another job of the liver, is to make cholesterol. Liver can convert some of the fatty acids into others. We have 2 essential fatty acids that we cannot synthesize ourselves. One is called omega-6s, and that's linoleic acid. We have linolenic acid, which is a little bit different. So there's a difference there. And it's omega-3 fatty acids, and both can be found in most vegetable oils. So we're always hearing about how omega-3s are good for us, omega-6s are bad. It's about balance, guys. Okay, and what do we use lipids for? Adipose tissue, remember, we need a little bit of it for protection, insulation, and fuel storage. Phospholipids that we find in the cell membranes and myelin sheaths and nerves, super important there. Cholesterol helps stabilize the membranes, precursor to the bile salts. Remember those steroid hormones that we learned about last week, super important for those being made. They make prostaglandins, which help control many things around the body, including inflammation. There are major lipids themselves, fat. Even though glucose is plentiful, skeletal and hepatocytes love to use fat as their major fuel source. And without fat, we can't get those the A, the D, the E, and the K in. So real world serving size is about the size from here, the first knuckle to your thumb. That is considered a portion of fat. Proteins, there's different sources from everywhere. I'm not saying one diet is good for the other. Ask your doctors about those. But animal products, eggs, milk, fish, most meats, soybeans, they're complete proteins. So they have all the essential amino acids that our bodies need to make other proteins. And then legumes, nuts, and cereals contain what's called incomplete proteins, which means that we lack some of the essential amino acids. And then when we combine some legumes and cereal grains together, they can get all the essential amino acids. So sometimes with vegans, you might hear that they eat rice and beans because that makes a complete protein for them. So here's a breakdown. I don't want you guys to memorize all the different amino acids. Just know there's 20. What do we use proteins for? We use it to build anabolic, right? So we use it to make keratin, skin, hair, nails, muscles, you name it, it's made from it. And there's 3 factors that help determine whether amino acids are used, synthesized as protein or burned as fuel. And it's an all or none rule, which means all amino acids need to be present for protein synthesis to occur. If not all are present, then amino acids are used for energy. So that's why it's really important to have all of them there. If we have adequate caloric intake, then we have an adequate amount of protein. If we have too much protein, guess what? Protein can be stored in different ways. And then hormonal control, so anabolic, remember protein anabolic, so growth hormone and sex hormones can help stimulate growth protein synthesis. And then those glucocorticoids, the cortisol released during stress can break, not stress, I'm mixing up two words, stress. They help promote protein breakdown and conversion of amino acids into glucose. And then also protein's super important. We'll get into this more into kidney, but they need a nitrogen balance. So homeostatic state of nitrogen balance is where our rate of synthesis equals our rate of breakdown. A positive nitrogen balance is seen where synthesis exceeds breakdown. This is normal to see in children, pregnant women, and tissue repair. And then a negative nitrogen balance, we see this in highly stressed out, burns, infections, injury, poor dietary proteins, or starvation. A lot of times we will see a poor nitrogen balance in an anorexic patient. And as far as dietary requirements, these requirements are dependent on how old the person is, the size of their body, their metabolic rate, and their nitrogen balance. The rule of thumb is that your daily intake is 0.8 grams per kilogram of your body weight. American diet, standard American diet, the sad diet, yes, it's very sad. American diets provide much more than we need of protein. Too much excess of anything gets stored in a way we don't want to use it. So real world scenario, the size of your palm minus your fingers is, and about the thickness of a deck of cards is a size of protein for you. So what do vitamins and minerals do? So most vitamins work as coenzymes, which they help other things work. Most of them are ingested except for vitamin D. I mean, we can take vitamin D supplements, but vitamin D is made by the skin from the sun. Remember that. Some vitamin B and vitamin K is synthesized by the intestinal bacteria. And then beta carotene from carrots is converted in the body to A. So beta carotene we do not have ourselves. And no one food group contains all these vitamins, which is why it's really important to eat the rainbow. I'm not talking about poop from a unicorn's butt. I'm talking about eating a colorful array of vegetables. Roy G. Biv, finding fruits and vegetables that get every spectrum every day at every meal possible. So which one do you pee out? The biggest question is that I always get is how do we know which vitamins are stored and which ones are bad or which ones are not? Water soluble vitamins are the B complex, B12, and vitamin C. So if we have too much, basically what happens is we pee it out. And fat soluble vitamin, and that's because remember, fat is able to diffuse through the plasma membrane. So A, D, E, and K, these are absorbed lipids. And if we excessively consume these, we can cause major health problems. Too much vitamin A is really bad. Too much vitamin D is really bad. E and K. Okay. And then we have something called antioxidants, which some of you may or may have not heard about. So things in our daily lives cause what's called free radicals. And these free radicals not only are done through things like sun exposure and environmental exposures, but they're also part of our normal metabolic processes. So vitamins C, E, and A, and a mineral called selenium are considered antioxidants. And what they do is they neutralize these free radicals. So free radicals end up free radicals are the precursors to cancer cells. So we don't want free radicals to damage our DNA and cause mitotic disruptions or mitotic overeruptions. So how do we get these antioxidants? We eat broccoli, cauliflower, Brussels sprouts. These are all good sources of A and C compounds found in food that are high in antioxidants. So anything that has a color to it, for polyphenols, give it that purpley blue color. Carotenoids, give it that yellowy orange color. Eat the rainbow. Get your antioxidants on. Okay. As far as minerals, we have 7 minerals that we require in moderate amounts. That's calcium, phosphorus, potassium, sulfur, sodium, chloride, not chlorine, it should be chloride, and magnesium. We've learned about many of the different reasons what these minerals are used for. So I'm not going to really go into depth, but most mineral-rich foods are vegetables, legumes, milks, and some meats. And uptake and excretion are balanced because if we have too much of one versus the other, we can actually cause toxic issues. As far as metabolism, I've already went into this a lot. Anabolic means building, catabolic means breaking down. So the stages, first we digest, absorb, and transport, then through cellular processes in our cytoplasm, we're synthesizing lipids and proteins and glycogen from what we've broken down, or we break it down to make that ATP. So catabolism is also known as glycolysis. It's anaerobic. It's taking that the glucose into making into 2 pyruvic acids and eventually acetyl-CoA that goes into the Krebs cycle. And then the Krebs cycle, its job is to bring things ready for what's called electron train transport, which is found in mitochondria. And that produces water, CO2, and ATP. And that's how our energy gets on. Cellular representation is respiration is there's aerobic and anaerobic. So anaerobic is just the glycolysis. Aerobic is the glycolysis, the Krebs cycle, and the oxidative phosphorylation chain, or here. So here's a little bit of breakdown. You guys don't have to know exactly what's going on here, but here's how everything works to make that ATP. Remember, it's all about getting that ATP out of things so we can have energy to do things and to rebuild things and repair things. So if you click here on this little video, you will see the differences between Krebs cycle and glycolysis. The big thing here is glycolysis. Anaerobic. Krebs cycle is aerobic. And glycolysis only yields 2 ATP. Krebs cycle yields 32 to 36 ATP. Okay, and what we didn't go into major detail in week 1 was what happens after the Krebs cycle. We need a couple things to happen. We have something called electron transport chain and oxidative phosphorylation. Oxidative phosphorylation is called excuse me, the first part of it is electron transport chain. And what that does, it creates protons or H+ ions that make a gradient across the mitochondria. And from that gradient cause ATP to be made. And then through chemiosmosis is using that energy from the proton gradient that actually makes the ATP. So fun fact about cyanide, so the gas that was used in gas chambers, it disrupts the oxidative phosphorylation and therefore you can't make ATP. It blocks one of the complexes that you need to help use oxygen, and that's why it's a poison. These are going to be common terms you're going to see mixed up. So remember that homeostasis, hemostasis, guess what? Now we got glycogenesis, glycogenolysis, and gluconeogenesis. I need you to understand the differences because these are common things to ask about. So remember that cells cannot store large amounts of ATP. When you have rising levels of ATP, it's going to tell the body to stop breaking down glucose and promote glycogen or fat formation. So glycogenesis is the formation of glycogen. We have too much glucose. Glycogen is stored in our skeletal muscles in our liver. Then we have glycogenolysis, which is the breakdown of glycogen through a process called glycogen phosphorylase, which is an enzyme, and that helps break down when our blood sugar is really low. Glucagon is going to come in. It's going to cause this glycogenolysis to break down the glycogen, so we can have some glucose to give our cells. Then we have gluconeogenesis. So neo means new. So we're making glucose from non-carbohydrate sources. So this occurs in the liver, and this helps prevent damaging effects of hypoglycemia. Without glucose, we can actually damage our nervous system. Now, I'm not going to get into the whole debate about the ketogenic diet. It works a little bit different. I'm not going to get into the logistics of that. So lipid metabolism, we break down in a special way. It's called, so lipids, they provide them greater energy yield from glucose or proteins. So fat tends to yield 9 kilocalories per gram versus carbohydrates, or proteins, which only yields 4. So most of our fat digestion are transported in lymph as chylomicrons. Remember, we talked about those already. We have hydrolysis through the brush border enzymes that break into fatty acid and glycerol, which is the phosphate backbone. We have the triglycerides are the only thing that we routinely use and oxidize for energy. And how do we do that? It's called beta oxidation. It occurs in the mitochondria. It breaks down fat so we can use it for fuel. When we try to lose weight intentionally, we increase our beta oxidation capacity in the mitochondria to use this as a fuel source. And then we have lipogenesis, which is triglyceride that's made when their glucose levels are too high. Okay. So too much glucose, too many carbs can actually cause more fat. So when people say they have hydroglycerides on a fasting blood draw, it actually tells me that they have way too many carbs in their diet, not so much about the fat. Okay, so this is why we always recommend to avoid sugars, because sugars, if in excess, will cause fat formation. Not that fat's bad, but too much is not healthy either. So we break down fat, we get what's called a ketone body. And the ketone body can enter Krebs cycle to be used for ATP. This is known as ketogenesis. This is ketone bodies, this ketogenic diet. I'm not going to go into much detail about that. So lipolysis is the breakdown of fat itself. So the glycerol, the phosphate backbone, and fatty acids. It's the reverse of it. So fatty acids are preferred sources of liver, cardiac muscle, and resting skeletal muscle for fuel. And lipolysis is accelerated when we don't have enough carbs in intake. So a lot of people do these low carb diets because if there's not enough glycogen to break down to make glucose, then guess what? It goes next to fat. So quick summary is that beta oxidation converts fatty acids into acetyl-CoA. Lipolysis breaks down the fat. Lipogenesis makes the fat. I'm not going to even go into this on keto diet because I am done with the keto diet talking about it in practice. Okay, so proteins deteriorate over time, so they continually need to be broken down and replaced. So amino acids are recycled into new proteins and different compounds, and proteins are not stored in the body really much, but I do have to say that so when we have too many proteins in our body, we have too many amino acids, guess what? That will be converted to fat storage or oxidized for energy. That's it in a nutshell. This is me in a nutshell. You guys will be doing a diet journal, a couple of fun labs. There'll be a quiz this week, and then don't forget about your test next week. Thank you so much. Have a great day. Bye-bye.